Okay, so good morning. Yeah, good morning. Yes, yes, yes. We're going to go ahead and get started. I want to definitely honor your time, and we need to maximize the time because we only get 1 hour. So welcome to the GW Health Sciences Health Equity Professional Development Learning Series. I know a good number of you, but not everyone. So I actually want to just introduce myself. My name is Dr. Miranda Ward, and I'm an assistant professor in the Department of Clinical Research and Leadership here in GW School of Medicine and Health Sciences. So I see a lot of you actually were here for our very first kickoff lecture, Framing Health Equity, but just in case you weren't, no worries, because all of the events in this lecture series are actually recorded. So you actually can go to the event website and you'll see that the recordings of every event is actually archived. Just click watch recording to tune in to what you missed. And so what I wanted to talk about today is, before I turn it over to our speaker of the hour, is that, again, given the format, because we're trying to make this lecture series accessible. So we are live streaming it right now through WebEx. We are recording it. So again, we can have it on the archive. And for that reason, it's very unfortunate that it's not going to be as interactive, because we want to make sure that we get through all of the lecture slides so we can meet the objectives for the CMEs. And then also we want to make sure that those who are online can actually hear. And so we have to speak into the mic, and then just having a discussion makes it more difficult in that way. So we're going to get through the slides, stop the recording, and then have a discussion. So that's the game plan. So I do want to say that even though every event in this series has its own measurable goals and objectives, the overarching aims of the entire series is listed here. So ultimately, we really recognize that, yes, we want to move the needle towards health equity, and we realize there are a lot of challenges, right? We have to address the multiple factors that literally threaten health equity. And so we actually have to have the requisite skills and capacity to address those ongoing challenges. And so this series is designed to do just that: develop skills, build awareness and knowledge, so that you feel that you're up to that challenge, depending on, the work that you do. And ultimately recognizing that this work can't be done alone. So we definitely have to work in tandem, in concert with other like-minded individuals and institutions. So we have to seek out those partnerships. And so speaking of working in tandem with others, this past summer, I actually worked alongside many other public health professionals to actually come up with what are some topics, what are some speakers that would really make this series kind of come alive. And so I wanted to, give credit to where that's due, and also recognize that one of the first names you see is our very own Abby Charles, who's here with us today. She's also on that review committee. And so I will say that Abby and I go way back, right? This is my pre-GW days when I was working as managing the adolescent prevention education programs at Children's National Medical Center, and she was working with an organization called the Women's Collective, and we were doing very community-facing work as community educators that we were and that we still are. So fast forward time, here we are. She's now the senior program manager at the Institute for Public Health Innovation, and she was able to secure her organization to serve as an official partner on this series. So thank you so much, Abby. We really appreciate that. And I also definitely want to recognize my chair, Leslie Davidson, because the Department of Clinical Research and Leadership is actually the official sponsor of this series. And so when we kicked off the discussion around health equity, we had an opportunity to be very clear in defining concepts and distinguishing health equity from health inequity and what is a health disparity. So Abby actually is going to pick up where we left off, just to refresh our memory of what exactly are we talking about when we say health disparities, because she actually is going to walk us through lots of data on the socially disadvantaged populations that actually are bearing the unfair burden of disproportionate disease and poor health outcomes. So with that, please join me in welcoming Abby Charles.
Good morning, everyone. It is such a pleasure to be here. I was just telling Miranda that, when you look at the whole series, the data series is like, I was like, I didn't get the most fun one, but I did get the session where we really get to set the foundation for some of what we need to be talking about as it relates to equity. As Miranda said, my name is Abby Charles, and this is not me, but this is where I'd want to be right now, as it starts to get colder in the District of Columbia. But seriously, this is a reminder of who we do this work for when we talk about equity, right? We're talking about our children, the next generation, and I like to be reminded of the fact that as we talk about disparities and inequities, and as we strive for equity, we're really striving to create a world where this girl has no barriers, right? And she has the opportunity for choice in an environment that allows for safe and healthy and well choices, right? But this picture also reminds me that there is so much resilience and strength in our communities. And when we talk about data related to inequities and disparities, it could sound like it's really negative, right? But we have to be reminded that in each of our communities, there's so much strength, there's resilience. And as such, identifying these inequities, we don't want to necessarily think of it in entirely negative ways. We want to think about the fact that we are identifying these gaps, these inequities, so that we can continue to strengthen our communities, right? And I say that especially because as we do trainings across communities, what we hear a lot is that, when you show this data to different communities themselves, they're like, why make it sound so negative? We have strength, right? So we want to make sure that we are remembering that as we talk about inequities. I have no disclosures, except that I am not American. I am from Trinidad and Tobago originally. That's my disclosure. So I'm looking at this data from the US as someone who is also an international immigrant, right, to the United States of America. So it's extremely interesting to look at this data from an international perspective, as well as someone who's lived in the US since 2000, so over 19 years. All right, so Miranda gave us a great introduction last month where we talked about the differences between disparities and inequities. So when we talk about disparities, we're talking about health inequities, health inequalities that are considered unnecessary, avoidable, and unfair or unjust. And that's the definition from the World Health Organization. When we do our work in health equity, we just say that a disparity is a difference. And a health inequity is a type of disparity that really digs into the fact that there are avoidable inequalities in health between groups of people within countries and between countries. But in the US, it's looking at the inequities in the US, right? And these inequities arise because of social and economic conditions that affect people's lives and determine their risk of illness and the actions that they're going to take, right? So today we're going to identify some of those well-documented US groups that are most disproportionately impacted by health disparities. I'm also going to look at some of the groups that are underrepresented in research. So those include LGBTQ populations, Native American immigrants and disability communities, as well as others that may not be included in what I present today. And then talking about some of the funding policies and priorities that maintain gaps in some of our knowledge, practice, and research, and how we can maybe look at opportunities to increase the research on some of the groups that we don't have enough information on. Now, I can't cover every population. That's not going to be possible because we only have an hour and we want to have some time for discussion as well. So I'm going to move fairly quickly through some of the data. As this is both online as well as going to be recorded, it's going to be more of a talk rather than an opportunity to ask questions as I speak. But hopefully we'll have about 10 minutes at the end to answer questions. All right, so I can't talk about disparities without saying that the US is a disparity in itself. We are an anomaly in health and social service spending patterns. And when you look at this chart, which was highlighted in Vox and is from the OECD, what we see here is that as compared to other countries of that are financially well off, the US has the highest health expenditures as a portion of GDP, gross domestic product, lowest social service expenditures as part of GDP, right? As compared to other countries. And what does that result in? That results in the lowest life expectancy or lower life expectancy as it relates to health expenditures as compared to these same other developed countries, right? So we see it manifest in outcomes, the results of our spending patterns nationally, right? And it's not just life expectancy, it's also child mortality, right? The US has one of the higher rates of child mortality as compared to these other countries. And it's also maternal mortality, right? The US has one of the highest maternal mortality rates as compared to all of these other countries. And I want us to keep that in mind, in that disparities will exist within the US population, but we are itself a disparity. And we have a lot of work to do as it relates to how we invest in the social fabric of this country in order to make this transformation. So when we look at health and heart disease, and I'm going to walk through some indicators initially, some of the leading health indicators in the US first, and then we'll also look at, by different population groups, what we're seeing in terms of disparities or inequities. So when we look at heart disease, what we see is that Black, not Hispanic individuals have the highest age-adjusted death rates for heart disease by race. So when you look at this chart, we clearly see that African Americans, Black individuals in the US have those highest rates of death. But it's not just death rates to heart disease, it's also the risk factors to heart disease. We see that there is disparity. So, oh, did I do that again? Sorry.
That's no worries.
So when we look at hypertension, what we see is that Blacks also face the highest rates of hypertension, most likely to have hypertension. We also see that for obesity. We also see that for diabetes. We see Hispanic and Black or not Hispanic individuals have those highest rates. And then when it comes to cholesterol, it's fairly across the board, right? When we think about cancer and cancer disparities, African American women are nearly twice as likely as white women to be diagnosed with triple negative breast cancer, right? As it relates to kidney cancer, the highest rates of kidney cancers and death in the United States occur among African American Indians, Alaskan Natives. When we look at liver cancer, rates of liver cancer are higher among American Indians, Alaskan Natives, and Asian and Pacific Islanders. Prostate cancer, we see that African American men are more likely than white men to die from prostate cancer. Cervical cancer, women in rural areas are twice as likely to die from cervical cancer. And multiple myeloma, African Americans are twice as likely as whites to be diagnosed with and die from multiple myeloma. Why is that when it comes to cancer? And what we see is that oftentimes cancer disparities really reflect the interplay of socioeconomic factors, culture, diet, stress, the environment, and biology. Regardless of racial or ethnic background, the poor and medically underserved are less likely to have recommended cancer screening tests than those who are medically well served. They're also more likely to be diagnosed with late stage cancer that might have been treated more effectively if diagnosed earlier, right? Even among higher socioeconomic status, though, certain racial and ethnic minority groups experience these significant cancer disparities, regardless of socioeconomic status. And those differences reflect mistrust of the healthcare system, a socioeconomic factor, and social determinants of health, fatalistic attitudes about cancer, or apprehension or embarrassment about having certain types of medical procedures sometimes that are not necessarily communicated well by the health system. They also reflect geographical or other differences in access to quality care. And cancer disparities also reflect differences in clinical trial participation. And clinical trials often have low participation by racial and ethnic minorities, which raises the possibility that the results are not fully applicable to them. But why do they have low participation by racial or ethnic minorities? Are clinical trials designed in such a way to make it accessible for racial or ethnic minorities? It's a question. I don't need an answer right now. When we look at issues like maternal mortality, right? And in the US, the maternal mortality rate is already as much as 6 times higher than some nations. And it's the only place in the developed world where the maternal death rate is rising. Complicating the issue, nearly half of all US counties lack a practicing OBGYN. Nearly half. And data on maternal death is not consistently available in all states. When we look at the data, pregnancy-related mortality ratios are 3 times higher for Black women and 2.3 times higher for American Indian, Native, Alaska Native women than for white women. The data cannot be ignored. When we look at mental health as another leading indicator, what we see here is 1 out of 5 adults experience a mental health illness. 18% live with anxiety disorders. 7% live with major depression. 1 out of 5 youth ages 13 to 18 live with a mental health condition. 37% of students with a mental health condition drop out of school. And 70% of youth in state and local juvenile justice systems have a mental illness. We know that mental illness is a barrier to access to healthcare. It's a barrier to access to many of the social determinants of health as well. And it's a factor when we think about disparities related to health and social determinants of health, such as employment, access to quality housing. We know that mental health affects all of those issues, and as such, that further exacerbates the disparities that people living with mental illness experience. When we think about HIV, 1 in 7 of the 1.1 million people in the US living with HIV don't even know that they're infected. So HIV testing and access to HIV testing is not as prevalent as we would want it to be. 52% of all new HIV diagnoses in 2017 were concentrated in the south of the country. So South Alabama, Mississippi, we're looking at southern states are experiencing some of the highest incidence of new infections. So talking about geography, when we think about disparities, and what we see in the South is really conservative practices as relates to education and conversations about sex and sexuality, as well as inhibitive policies related to criminalization around HIV, as well as limited conversations about LGBTQ issues and a lot of stigma around sexuality and health as well. 43% of people newly diagnosed with HIV in 2017 were Black or African American, even though they only represent 13% of the US population. When we're talking about inequities, 43% as compared to 13% is like extremely high. Again, I'm going to move fairly quickly through these pieces because we have a lot to cover. When we look at, and I chose DC to highlight asthma because asthma is fairly prevalent in the District of Columbia, and our rates of asthma in DC, when we look at DC as compared to the nation, are fairly high. And this map comes from the Health Equity Report for the District of Columbia, which was released this year. And it maps and looks at life expectancy related to geography. And also this map specifically looks at the rates of asthma as it relates to geography. And if you know the District of Columbia, the areas in this map that show the highest rates of asthma are in Ward 7 and 8. So asthma is a condition impacted by environmental pollutants from outdoor and indoor sources. And the data available at the zip code level shows the differences in rates of pediatric asthma for children ages 2 to 17. And this looks at the rates, asthma visits to hospital emergency departments specifically. And looking at this, we can clearly see that asthma is not just an issue of geography, but you will see later on in my presentation that when you look at where African Americans are primarily located in the district, this maps very highly over the locations that African Americans are. So when we talk about disparities, it's more than just geography. There's an overlay and there's this complex interrelation of how these factors play out. So Miranda provided this chart to us last month, sorry. The population is more likely to be at risk for poor health outcomes. And we see that it's people who are children or minors, people who are elderly, people who are malnourished, people who are chronically ill, people who are not health literate, people who are underinsured, people living in poverty, differentially abled, people who are homeless, persons who are mentally unstable, system involved, people who are undocumented, people who live in underserved rural and urban areas, and people who cannot read, write, or speak English. And she categorized these in different groupings. The first group were people who are dependent on others. The second group were people who are have disparate access to resources. The third group were in green were people who are severely stigmatized. And I would argue to say that the persons in the blue categories are also severely stigmatized as well. And then the persons who are undocumented, live in underserved and rural areas, and who can't write or read English are often under-researched and left out of the conversation. So they're often silent, right? So these are the groups who I tried to focus on through some of our data. In complex ways. But when we look at disparities by population, and thinking about children, I decided to focus specifically on low-income children, right? And among all children under 18 years of age in the US, 41% of children are low-income children. 19%, which is approximately 1 in 5, are poor. And when we define poor, what we're talking about is between 100 and 199% of the federal poverty level, right? And the federal poverty level is, 16,543 for a family of 2 with 1 child. And you can see those on the chart there. This means that children are overrepresented in our nation's poor, right? They represent 23% of the population, but comprise 32% of all people in poverty. Many more children live in families with incomes just above the poverty threshold, which makes it challenging for them to have access to quality life. Being a child in a low-income or poor family does not happen by chance, right? And it's tied to significant structural determinants of health, such as parental education and employment, race and ethnicity, and other factors that are associated with children's experience of economic insecurity. Recently, the American Academy of Pediatrics released a policy paper on the impact of racism on child and adolescent health. And I think it's an important statement to make, because although we've made significant strides in addressing race as it relates to child health outcomes, racism continues to be a social determinant of health that affects these high rates of poverty among children. When we look at children in poverty, when we look at disparities by population, and we look at the percentages of children who are low income, poor, or in deep poverty, we see that Black and American Indians and Hispanic families make up the majority of these children. Not to neglect the fact that white, Asian, and other children and other people who identify as other also make up significant numbers of our homeless population who are children. Right. In addition, the percentage of children in low-income families varies by where parents are from. And we know that 51%, right, of children in low-income families came from families who are not parents who are not native born. Right? When we look at people with disabilities, and if you take the model of, there's two different models of disability. There's the medical model of disability, and then there's the social model of disability. And the medical model of disability takes it from the perspective of a person's disability is an individual thing that can be treated and is based on that individual's ability to move and or hear or see, and it can be treated by individual experience. Whereas the social model of disability sees the issue mainly as a socially created problem, right? And believes that no matter what, we must be able to fully integrate people into society, regardless of their individual ability. So disability is not an attribute of an individual, but rather a complex collection of conditions. However, when we look at how persons with disabilities experience the world in the US, we see that persons with disabilities are more likely to be unemployed. They're more likely to be victims of violent crime. They're more likely to experience cardiovascular disease, more likely to experience obesity, more likely to smoke, more likely to have no leisure time physical activity, right? They do have access to mammograms, but they're more likely to not be receiving their needed medical care because of cost as well. There's a significant dearth of information and data at the intersection of disability and race and ethnicity, and other personal characteristics as well, right? The barriers are complex and exist across many players, right? We just don't have enough information at the federal level as well as at the research level. But what we do know is that across time and looking at age-adjusted statistics for adults, it shows that there's a consistent pattern of more prevalent disability among African American or Black individuals, American Indian, Alaskan Native, Native Hawaiian, and other Pacific Islander, and multiracial respondents to this survey. On the other hand, relatively few Asians report physical disability, right? And physical disability prevalence among Hispanic and Latino respondents is similar to the prevalence among non-Hispanic whites. But we also have to look at across disabilities as well. So it varies significantly depending on the disability. And what I'd say is that we need significantly more research to look at different disabilities for different groups as we're thinking about health and health outcomes. Looking at disparities by population, and we want to take a look at people who are uninsured, right? So there was a recent study that showed that as it relates to insurance, you know, America is, of course, we saw it earlier, that it's the world leader in terms of inequality. And US working age adults are significantly more likely to have health insurance. We know that since the Affordable Care Act came into law. But although that is the case, improvement in uninsurance rates has stalled significantly. But in addition, people who are insured through their employers are most likely to be underinsured, right, as compared to, well, 2014. We're seeing the largest growth of insurance among people with job-based, the largest group of people who are underinsured. 41% of underinsured adults said they delayed care because of costs, compared to 23% of people who have adequate insurance coverage. And they also experience difficulty paying their bills. So almost half, or 45% of uninsured adults, report medical bills and debt problems, which was nearly twice the rate of those that are underinsured. Now, what does this mean, right? So, if we have a group of people who are employed and have insurance but are not receiving the care that they need, we have a significant challenge to health equity, right? Because there's a large group of people who are not accessing care. So, insurance does not equal health. Insurance does not equal health care. What we're also seeing related to poverty is that the divide is increasing between the richest and poorest Americans. So we're seeing that in households that are making less than $22,500 a year, 38%.
Sorry, we're getting some feedback on the WebEx.
1 second. A lot of information. So when we think about of people in households making less than $22,500 a year, 38% of those individuals reported being in poor or fair health, in a survey taken between 2012 and 2013, which is more than 3 times the rate of the health troubles faced by individuals in households making more than 47,700 a year, right? Which makes sense because people who are in lower income households are likely less able to afford some of the challenges related, some of the opportunities related to what is available in the health system, right? While wealthy people around the world generally have better health outcomes than their fellow low-income citizens, we see that in the US, the gap in health difference is among the world's largest. Of the 32 rich and middle-income countries studied, only Chile and Portugal had a wider separate in health and health outcomes between poor and rich than the United States of America, right? Not moving. Right. In a landmark study by Raj Shetty in 2001, what we saw was that life expectancy increased for about 2.5 years for the top 5% of the income distribution, but there were no gains for those in the bottom 5%, right, in the US. Men in the top 1% of the income distribution can now expect to live 15 years longer than those in the bottom 1%. And for women, that difference is about 10 years, which is an effect equivalent to that of a lifetime of smoking. Now, this comes out of a Health Affairs report in 2018, but what it speaks to is the fact that in the US, more so than in other countries, that income divide is creating a serious difference in life expectancy. And we're going to see that as well as we look at the District of Columbia, right? Where in the wards 7 and 8 and some others, where we see that there are highest proportions of people living in poverty, we also see that there is the lowest life expectancy in the district. We talked about the definition of health inequity. We talked about the fact that health inequity is unjust, avoidable. This is injustice. When where you live in a city is not necessarily based on choice at all, and your health outcomes based on where you were born can be determined just based on the income of that area, that's an injustice, right? So we have to ask the question, why do more people live in poverty when they live in Ward 7 and 8? All right, let's look at older adults. So our elderly population in the US, elderly people aged 80 to 90 is growing. Many people have physical and mental health problems when they hit the age of 80 and 90, live alone, rely on family, and can't afford to pay for help at home. They have little financial reserves. 1/3 of senior households has no money left over each month or is in debt after meeting essential expenses. And in 2015, 2.9 million households with a senior age 65 experienced food insecurity. Growing aging population. And our older adults are extremely vulnerable to health inequities. Investing the resources that we need to ensure that our seniors continue to have thriving lives as seniors. That's a significant challenge that we don't have enough research on either, senior populations. When we look at people experiencing homelessness in the United States, approximately 3.5 million people experience homelessness each year. Families with children make up 50% of the homeless population. And the amount of people experiencing homelessness is growing. Children under the age of 18 account for 25% of the urban homeless population. While circumstances could vary, the main reason people experience homelessness is because they can't find housing that they can afford. And it's the scarcity of affordable housing in the US that is a significant challenge that continues to increase our homeless population, particularly in more urban areas like the District of Columbia, where homelessness is more prevalent. That's behind their inability to acquire or maintain housing. People of color are more likely to get pushed into homelessness because they are more likely to have a criminal record, which makes it tough to find housing or a job, or they have a past eviction, or they don't have the money to pay rent, but they can't, or they have the money to pay rent but can't afford the security deposit. And we're seeing that more and more and more evictions and having an eviction on your record, a past eviction, leads to you not being able to access housing. For example, in areas like Seattle, Black residents are more likely to have an eviction listed on their credit report, even if they weren't even evicted, but they moved without giving notice for whatever reason. And these systems are creating more and more barriers for people of color to access housing. And as such, when we look at the homeless population and we think about in our Medicaid populations, etc., who are the populations more likely to be utilizing the emergency room for healthcare? We find that homeless individuals are make up a large proportion of those groups. And it's not a choice necessarily, right? Homelessness is definitely not a choice, but it speaks to systems and policies that are lacking to support this population. Another group that we could look at is rural America. Rural America has an older, sicker, and poorer population. And rural areas, a lot of medical providers tend not to opt in to being located in rural areas. They are more likely to want to be in urban areas. So when you look at the providers by numbers per 1,000 people, you could tell that the majority of them are 13 in rural areas versus 33 in urban areas. So we've created a system where persons who live in rural areas, whether by choice or not, do not have the same access to health as persons in urban areas, health care. The same we see with dentists, the same with primary care providers. There's a significant disparity in access. Over half of rural counties have no hospital-based obstetric services. So very few OBGYNs are located there. And it's a significant problem. Nationally, rural households have a lower median household income as well. So where it's a complex interrelation of factors. What we see as it relates to COPD, chronic obstructive pulmonary disease, which is a group of respiratory conditions, including chronic bronchitis and emphysema, we see that there is a much higher prevalence, and rural populations have more COPD-related issues due to more people smoking, increased exposure to secondhand smoke, and less access to smoking cessation programs as compared to people living in urban areas. People living in rural areas are also more likely to be uninsured and have higher poverty levels, which also leads to less early diagnosis and treatment. And in this chart, what this shows is that there are 7 states, Alabama, Arkansas, Indiana, Kentucky, Mississippi, Tennessee, and West Virginia, that had the highest estimates for COPD diagnosis, hospitalizations among Medicare enrollees, and death. So knowing that this disparity exists, we should be designing interventions to target these areas. And I know CDC is working on prioritizing these areas, but understanding that rural-urban divide is something that we have to address in order to get to a space where we have greater equity. Immigration status is also a significant factor, right? So when people in America are forced to live in fear because of their immigration status, their health and the health of our nation is going to suffer. Research shows that immigrant families often forego the needed healthcare and social services because they fear interactions with public agencies. Robert Wood Johnson supported study showed that factors such as inadequate healthcare, socioeconomic background, immigration status, limited English proficiency, federal, state, and local policies on access to publicly funded healthcare, residential location, and stigma and marginalization affected the fact that immigrants have lower rates of health insurance, are less likely to use healthcare, and receive lower quality of care than US-born populations, right? In addition, the toxic stress associated with the fear of deportation has shown to have harmful effects on an individual's long-term physical and mental health, and children are especially vulnerable to that type of trauma. That acts as a barrier to normal physical and mental health development for young people. Furthermore, fear of deportation has significant impact on the uptake of non-medical services such as food assistance that are important to good health. Our immigrant population cannot be ignored. And when we talk about immigration, we're not just talking about undocumented, we're also talking about refugees, right? So among legal permanent residents, refugees were significantly more likely to report chronic health problems than other immigrants, and half were uninsured, right? Refugees are older immigrants and have lived in the United States for a shorter period of time. When compared with other immigrants, the odds of refugees rating their health status as fair or poor and of having a chronic condition were higher, right? And of course, the impact of local immigration enforcement policies not only affects immigrant access to health, but it also affects when immigrant families have children who are citizens. Children who are citizens are less likely to access care when their parents are undocumented. We can't forget migrant farm workers, which is another group as well. We have a significant number of migrant farm workers who come to the US every year and are not able to access insurance, are not able to access healthcare at cost because of the amount that they are paid. Many of them are undocumented and fair accessing care. So we also have to remember migrant farm workers as we're thinking about what are some of the groups that are in the US on a regular basis that face health disparities. I'm going to move even quicker because I'm watching my time. But mass incarceration is another factor that threatens health equity in America, right? And as we think about mass incarceration, people of color represent 39% of the national population, but make up 60% of incarcerated persons in the US. And people with disabilities are 4 times as likely as non-disabled people to end up in jail. Incarcerated people have pre-incarceration median income 41% lower than that of non-incarcerated people. And many people are incarcerated because they cannot afford bail or court-imposed fees or fines. So when we look at this chart and we think about the cycle of health inequity that persons who've incarcerated face, and we think about the fact that there are many people who are incarcerated unjustly, we are creating a system of health inequity that is unnecessary among our incarcerated populations, right? Mass incarceration extends far beyond the jail cell, right? In reality, mass incarceration affects the children of persons who've been incarcerated and their families. Parents' incarceration influences children's educational, economic, and social opportunities, which in turn shape the children's health throughout their life. Mass incarceration, of course, disproportionately affects people of lower economic status. And the inequitable policies and practices drive dramatic disparities in incarceration, right? Mass incarceration harms our entire nation. When we think about race, and we could think about multiple races, but specifically as we think about race and health inequity in the US, a Black woman is 22% more likely to die from heart disease than a white woman, 71% more likely to perish from cervical cancer, and 243% more likely to die from pregnancy or childbirth-related causes. Think about race. Race, firstly, should not be conceptualized as a proxy for class, right? We have to look at race and class as separate concepts. Think about the fact that being Black is associated with additional excess risk for certain conditions, such as 243% more likely to die from pregnancy or child-related birth causes. We have to start looking at race and class separately in our research. One of the main functions of racism in the United States has been to divide people with common class interests so that they're less able to struggle politically in their common interests, right? And an aspect of that function is to have made race a highly visible feature of our public policy without also taking into consideration the effects of class on these rates and relationships. The common accusation that any mention of inequality is tantamount to waging class warfare is a culmination of a long-standing ideological effort to suppress any consciousness of class. Inequality and race inequality must be looked at in an intersectional way, right? Race is a significant factor as we think about our inequities. But as scientists, we have to make sure that we are not perpetuating the concepts that there are certain races that are genetically predisposed to certain conditions. And that is a risk that we face as we talk about African Americans are more likely to have a certain condition. We have to intersect our conversations with the why. And the why is related to the fact that African Americans are more likely to be living in unemployment or living in poverty or living in cities where there are conditions such as what we see in the District of Columbia. This is just for the United States. When we think about the LGBT community, LGBT individuals encompass all races and ethnicities, religions and social classes. Sexual orientation and gender identity questions are unfortunately not asked on most national or state surveys and make it difficult to estimate the number of LGBT individuals and their health needs. Research suggests that LGBT individuals face health disparities linked to societal stigma, discrimination, and denial of their civil and human rights. And what we see here in this chart is that as it relates to HIV, men who have sex with men have by far some of the highest rates of new diagnosis of HIV infection in the United States. And this disparity is tied to stigma, discrimination, and denial of civil and human rights for LGBT individuals. Discrimination against LGBT persons has been associated with high rates of psychiatric disorders, substance abuse and suicide, experience of violence and victimization are frequent for LGBT individuals and have long-lasting effects on the individual and the community. Family and social acceptance of sexual orientation and gender identity affects mental health and personal safety of LGBT individuals. And we see in this graph that talks about the suicide rates among the US, that LGBT youth are 4 times more likely to attempt suicide than straight youth. These disparities cannot be ignored.
We have less than 10 minutes. So did you want to stop and take questions, or do you want to power through the slides?
I just want to get to one slide that highlights where we need to get to as it relates to research. So when we think, because the next set of slides were on DC anyway, so we should be fine. But when we look at the disparities in research, what we recognize is that not all populations that experience disproportionate morbidity and mortality receive equal attention from health services researchers and their funders, right? So while the Hispanic Americans, as well as groups from lower socioeconomic status backgrounds, are well represented in disparities research, populations, LGBT, American Indians, Native American populations, and persons living with disabilities are underrepresented relative to both the severity of health and healthcare disparities that they experience and their representation within the American population. And this chart sort of highlights that, right? In addition, when we look at the type of issue, we're also seeing that there's a significant disparity in what is being researched, right? So healthcare delivery, cancer, diet, mental health, and prevention, screening, and HIV/AIDS are at the top, whereas we see issues like asthma, kidney conditions, oral health, mortality, STDs, and sexual health lack research. So we must do more research as it relates to these significant issues that we see disparities in as well. Now, there's a need for interventions that incorporate the engagement of patients and of stakeholders more broadly in developing, testing, and disseminating work. Looking at all this data that we've seen as it relates to disparities, one of the biggest issues that we see nationally as it relates to research is that the groups that are facing these disparities are not engaged in research processes in effective ways. So as researchers, as we are encouraging researchers to get into the community, it is important that once disparities are identified, it's our responsibility to engage those communities in the process from the beginning, right? In the United States, racial and ethnic minority, rural, and low-income populations continue to experience suboptimal access to quality healthcare. However, many healthcare interventions that were designed to achieve health equity fall short because of the gaps in knowledge and translation as it relates to these populations. When we talk about equity, we tend to use the following equity framework. And as it relates to this data that I've presented, what we're trying to do is we want to identify where inequitable outcomes exist and who the populations are that face those great inequities. We want to identify the distribution of social, economic, and environmental determinants of health and disaggregate our data by race, income, gender, disability, place, sexuality, gender status, gender identity, all of the above. And we want to ask the question of who is marginalized, why, and what are the structures that are creating the inequitable outcomes. So it's not just as simple as saying that these are the groups that face inequities. It's also extremely important and just as important to ask the question of why. And that has to be communicated in tandem with our disparity data. Otherwise, we are reinforcing and not necessarily, we're perpetuating the injustice and not necessarily really working towards equity. Any questions?